As we know, the technical Achilles heel of angioplasty is stent restenosis or restenosis of the vessels. This is the medical Achilles heel, actually, contrast-induced nephropathy. So this we should know what are the important factors, how can we prevent, and if it occurs, how we manage it, we should know. So fundamentally, before going, we should know these are the learning objectives, especially we should know the types of the contrast media, and we should understand the pathophysiology, risk factors, treatment and preventive strategies of contrast nephropathy, and superiority and safety of isoosmolar contrast media, and importance of choosing of the right contrast media, along with taking the risk factors of the patient who develop contrast nephropathy. So, as we know, contrast media are indispensable radiology, safer and better tolerated due to significant improvement in composition, and adverse effects can vary from minor to rare severe life-threatening situations. So, essential to be prepared to manage the entire spectrum of the adverse events. Important to identify which media has the best risk versus clinical benefit profile. So, these are the ideal properties of contrast media, which is water soluble, chemical and heat stability, biological net, low viscosity, safety and low cost. And if you take the evolution of the contrast media, almost they came from almost high osmolar, that is 5 to 8 times of more osmolarity, and isosmolar, almost equal osmolarity of the blood. It was evolution in the development of the contrast media. And if you take the ionicity, and initially the high osmolar ionic, which are associated with high complication rate, and in the evolution it comes to the almost low osmolar or isosmolar non-ionic contrast, which is 280 milliosmoles per kg, which is almost equal to that of the blood. And by definition, contrast nephropathy is acute kidney injury within 48 hours of exposure to intravascular radiographic contrast material, and which is not attributable to other causes, and which is associated with increase in serum creatinine levels between 25 to 50% from the baseline, and increase in absolute values of 0.5 to 1 milligram per deciliter from the baseline. So these are the contrast media, how it produced. By means of it will cause a decrease, that is vasoconstriction, and reduce the GFR by this algorithm. That means red blood cell aggregation, vasoactive mediators, and increased diuresis, which ultimately leads to the decreased glomerular filtration. And also high viscous, it will produce increased renal tubular viscosity, and renal vascular resistance is increased. Ultimately, all these factors with chemical injury of the tubules, it produces reduced glomerular filtration. In patients with already diabetic patients, as well as those patients who have a compromised kidney function, the contrast which enters the renal vasculature, which will cause endothelium dependent transit vasodilatation, and that leads to the adenosine release from macula densa, which will cause a tubuloglomerular feedback, and endothelins release and prostaglandins dysregulation. Ultimately, all of them leads to sustained intrarenal vasoconstriction over the hours that lead to the acute kidney injury. So the incidence epidemiologically, it varies from 1 to 6% in general population. Of course, those patients with diabetes and pre-existing renal disease, almost more than 50%. Diabetes people especially, total 9 to 40% of patients with mild to moderate chronic renal insufficiency are prone for these contrast nephropathy, and severe CKD diabetic patients are more than 50 to 90% of CIN. And this is the third most common cause for acute renal failure in hospitalized patients. Why this is most important? Why? Because the patients who develop contrast nephropathy, the cumulative mortality is very high, in hospital mortality after the occurrence of the episodes of CIN. And these are the risk factors you have to identify in the patient who are prone. Already patient have compromised kidney function, and diabetic patient with renal insufficiency, elderly people, volume depletion, hypotension, low output, and class 4 heart failure, as well as post-renal transplant and hypolminemia. Of course, procedurally it is multiple contrast media injection within 72 hours, and intraarterial injections, and high volume of the contrast media and high osmolar contrast agents. These are the subset where the occurrence of CN is very high. And if you take the risk factors which contribute to contrast nephropathy, is impaired renal function. As the kidney function is more and more compromised, they are more and more prone for contrast-induced nephropathy. And diabetes mellitus is an important significant risk factor for contrast nephropathy by means of enhanced renal oxygen radical stress in the kidney tubules, as well as intensified renal parenchymal hypoxemia along with the tubular and vascular endothelial injury, which leads to reduction of the effective glomerular filtration and contrast nephropathy. This is a diagrammatic depiction of arterioles without contrast media, how the lumen of the afferent arteriole you can see, and with contrast media without diabetes, the once exposed it will cause renal vasoconstriction. In diabetic people, much more vasoconstriction, which will they are more prone for contrast nephropathy. And there is a correlation between diabetes and renal function as a risk factor of contrast nephropathy. As the renal function is less and less, they are more prone for contrast nephropathy by further reduction of the effective glomerular filtration. So what are the clinical features? So mainly it is a non-algoric or asymptomatic transient decline in renal function, especially serum creatinine begins to rise within 24 hours, peaks around 5 days and return back after 2 weeks. Whereas a more severe variety, that is algoric renal failure, which require dialysis, oliguria occurring within 24 hours and peaks around 5 days, and serum creatinine levels after 5 to 10 days of peaking, it slowly comes to the baseline around second to third week, and morbidity and mortality rates are significantly higher in algoric type of acute kidney injury. So this is the treatment. As we know, once the patient has acute kidney injury, you have to monitor the serum electrolytes and prevent especially hyperkalemia, hyponatremia and hyperphosphatemia, as well as hypocalcemia, and appropriate nutrient support and strict recording of the patient weight and fluid input is important, and phosphate binders are also needed, and dietary restriction and potassium binding resins are important, along with insulin dextrose infusions when potassium is very high, and correction of acidosis is important with oral sodium bicarbonate, and temporary dialysis in patients with severe algoric renal failure, and some patients may require permanent dialysis or kidney transplantation also. So the consensus guidelines for the prevention is the general guidelines. When patients, all patients with eGFR less than 60 ml per minute, avoid dehydration and consider alternate imaging strategies not requiring iodinated contrast material, and minimize the contrast medium volume, avoid repeated iodinated contrast studies within 48 hours. This is most important because the volume control is also very, very important, and use low or isoosmolar, especially isoosmolar non-ionic contrast, which is safer to the kidneys. And patient who have eGFR less than 40 ml, who requires intravenous contrast administration, and with mild to moderate risk of contrast nephropathy, IV hydration is needed prior to the procedure, and you have to avoid dehydration with oral fluids or IV hydration. And when patient have eGFR less than 40 ml and any patient with associated illness or unstable renal function, although hold nephrotoxic drugs like NSAID or diuretics, and hydrate with IV sodium chloride or sodium bicarbonate, and consider N-acetylcysteine, and follow up with serum creatinine as well as eGFR around second and third day. Always this is the most important factors we should grossly is avoid dehydration, adequately hydrate before taking the procedure, and you select the contrast media, that is isoosmolar agent, non-ionic agent. So increasing incidence of CKD and diabetes is likely to make prone for contrast nephropathy, and it is a challenge for treating physicians. So identification risk factor is crucial in prevention of contrast-induced nephropathy, especially those who having isoosmolar agents, non-ionic contrast agents should be selected, which reduce the incidence of contrast CIN. And there is a positive correlation between contrast nephropathy incidence as well as osmolarity. As the osmolarity is high, more incidence; as the osmolarity is low and isoosmolar, it is less incidence. So same diabetic depiction, which is graphical depiction, which is showing diabetic as well as CKD, the patients are more prone for contrast-induced nephropathy. And not only along with CIN and with isoosmolar non-ionic contrast have low primary outcomes and high angiographic success rate, as well as they have low potential for major cardiovascular events also, especially isoosmolar non-ionic contrast medium. And renal safety is also high in isoosmolar non-ionic contrast. And not only these hypersensitive reactions, they are least in patients with those who are exposed to isosmolar non-ionic contrast media. And apart from these, discomfort levels are less, as well as the pain incidence is also less in patients who are exposed to these agents. And this is the important graphical presentation, and where the various studies are showing the contrast in nephropathy is less with isosmolar agent, which favors iodoxanol compared to low osmolar contrast agents. So ultimately the key take home points are proportional decrease in toxicity as osmolarity reaches the serum concentrations, and direct relation between contrast nephropathy as well as mortality. So you have to prevent the best measures. Important factors in prevention are avoiding of dehydration and selection of the contrast medium, and use of isoosmolar contrast agents with low prevalence of contrast nephropathy and major cardiac events.